Hi there. Joining us today is Dr. Christine Armour, a pediatric geneticist at the Children's Hospital of Eastern Ontario, CHEO, and an associate professor of pediatrics at the University of Ottawa. Dr. Armour will discuss her team's innovative AI-generated algorithm predicting risk of autism spectrum disorder in very early childhood using a combination of mother-child medical databases. So today I am speaking with Dr. Christine Armour, and thank you very much for coming to speak with us this afternoon.
Thank you very much, Kathy. It's a pleasure to be here.
So, I could give a full academic kind of presentation about your degrees and your everything else about you and where you are. But instead, I think it might be a little more interesting for our listeners if you could just tell us a few sentences about who you are, how you got into this business, whatever you'd like, whatever you think is important for them to know.
Yeah, wow. Well, I'm born and raised in Ottawa. Grew up here, local. Most of my education was around here, except for some detours around other parts of Ontario. Have an undergraduate degree in biology, so sort of very general, even like plants and other things, and then moved into more laboratory work, and then went to medical school, and then went back to laboratory work, and then actually spent my core residency training in genetics, which is actually very different from this research that we're talking about today, but has led me in sort of a circuitous path to get to where I work now, which is with the Better Outcomes Registry Network, which is Born Ontario.
Well, thank you very much. It does sound very interesting. The journey sounds quite interesting. You mentioned something that you started off in genetics, and it's not exactly what you're doing now, and with this project was a little different. So can you tell us how you wound up doing something a little different than straight genetics, what you were doing before and what you're doing now?
Yeah, so it's been a path where I look at a whole bunch of different ways that we can care for the population, if you will. And so I started off through genetics, being interested in prenatal screening and how we can offer that, how we deliver it, how we run that program well. And I still do a lot of prenatal care in my regular genetics clinical role. But as I moved through that path, I became embedded in these, or attached, I guess, to these very large organizations like Born, and realized the opportunities that some of that large data presents to us. And the data it's really, I feel like, well, it's a resource for healthcare in Ontario. And I think I'm both excited to look at that data and figure out different ways that we can use it to improve healthcare. And in this particular instance, it's for mental health. But in other instances, it's for different ways that we can care for the population.
Can you please tell the listeners a little bit more about what Born is and where are the data housed?
Yeah, so Born is a registry, which means it has the ability to collect data from multiple sources across the province, so laboratories, hospitals, midwifery practices, all sorts of places, under legislation, and they do that with deep respect for privacy. And the goal is to improve maternal child health with the use of that data. So we look at all kinds of Born as an organization, not me personally, look at all kinds of ways that how maternal newborn child health is running in the province, and what kind of metrics we can look at, what kind of quality assurance. Are there ways that there's gaps in care and we can improve it, those sorts of things. And that's what the organization does. It is actually housed at CHEO, the Children's Hospital.
That sounds like an enormous amount of very valuable data.
It is. It definitely is.
And so it's about data from mothers who are pregnant and have just delivered, and then their newborns.
Correct.
And then you said children also?
Well, there's not a lot of child data in there, but there's starting to be some. So there's some neonatal care data. And then there's other pieces that have accumulated over time. And then there's also a pediatrics diabetes database, which is growing. So there's pieces, but the child part is not yet as large as the maternal newborn part.
I see. And in terms of trying to do something with precision child and youth mental health, do you have to look elsewhere in other kinds of databases?
Yeah, absolutely. So, for example, in this study that we did, we collaborated with ICES.
And what is ICES?
It's the Institute for Clinical Evaluative Sciences.
Oh, okay. So it's separate from BORN.
Correct.
And how can you combine that information with BORN? What do you look for in that database?
So ICS collects data from quite a number of sources. I am no ICS expert, and nor can I speak for them. But as I understand it, they have data from many sources, and with special permissions and access, we were able to use some of that data.
Does every province have big data sets like this?
It's difficult for me to speak to exactly what exists in other provinces because I'm not as familiar, but certainly I think Ontario, from what I understand, Ontario has world-class data. And so I think we're incredibly fortunate in this amount of data that we have, and that we can leverage it for healthcare.
And it's across the whole province, correct?
Correct. It draws from the entire province.
Okay. Well, this certainly gives you an interesting platform to start studying things. Can you tell us what you studied in this particular project that was looking for predicting a relatively problematic child mental health problem?
So we were interested in asking the question because I like to think of all the different ways we can use the data. Can we predict what is the chance or the likelihood that a child will have a diagnosis of an autism spectrum disorder by the age of 5 using this data and machine learning? And so this piece of work was to develop an algorithm. And so clearly that was with a larger team. And we have data scientists and machine learning experts who helped us develop this plan and develop the machine learning algorithm to take a portion of data to say, can we predict from that data what children are likely to develop autism?
Well, that sounds pretty impressive. So how did you go about combining data from all these different places?
So some of the databases that we have will cover, for example, so that we have access to that live at ICS or ICS has collected some of these data sources include discharge information, administrative health records. And by that, I mean, for example, diagnostic codes or billing codes. And then we are also able to link it with some of the information we have access to, for example, the newborn screening data and other data at born.
So you were able to then find kids that had diagnoses by around 5 of autism spectrum
Yeah,
disorder?
so the way it worked is first we designed the study to say, okay, if we have all this data and we know there's a population of individuals with autism spectrum disorder, first we have to teach the machine learning how to recognize those
I see.
individuals. After that, we take our sort of trial group and run it and say, okay, now we've protected some of this data that the machine learning has never seen.
Mm-hmm.
And now we run it again and see if it can actually, on a test run, identify a new group of individuals within that set of data.
And approximately how many cases or whatever were you working with?
So our cohort was over 700,000 matched
Wow.
mother-baby pairs. Yeah, it's a very large data set. And in the range of around 10,000 diagnosed cases of autism spectrum disorder.
Very impressive. So this is one of the things that is able to be done when you have this population-based information. So you first trained the system, then you tested the system to try to predict which one of those, whether it could identify those kids that you'd identified. So what kinds of things did you find?
I think the goal of the study was to try and see, is this even feasible?
So that was first. Had it never been done before?
Not like this. So I think there's other studies that have looked at trying to predict in different ways, but not exactly the way we did it. And so I think that was very novel. The size of the data, the linkage of the data of the mother-baby pairs, I think was very unique. It showed that it's feasible.
Okay.
And I think that was the value of the study. I think if we wanted to bring this any further, we'd have to continue to develop the model. So, for example, can we increase our data sizes? Can we improve the quality of the data? And try it with other pieces of information that we might be able to get, for example, laboratory data or any other sources that we might be able to eventually build into this kind of a study.
And what kind of gap did this study fill? I know it's not. I know you said that it needs to be. This was feasibility, but clinically, what sort of problem?
Yeah, I think as I like to think about screening systems and how we find or identify individuals before they've come to medical attention or the system attention, and what are ways to serve the population in that regard. And so screening systems and maybe predictive algorithms are one way to do that. Is this ever something that we could bring into a screening system? As you've heard me talk about, it's unclear, but I think it's the idea that would potentially it's a tool that might allow us to put a system into place that allows people to enter the system in a more consistent way, in a more equitable way, that's potentially even faster, for example, than what happens now. There are other screening systems that we have, for example, newborn screening or prenatal screening or different other medical specialty screenings like, cancer screening. It would be ideal to also, I don't know about ideal, but it would be, I think it could serve a different niche of mental health care if we had screening for mental health care conditions, including neurodevelopmental ones like autism, that we don't have now. And so that could be the space that this kind of work starts to contribute to.
Wonderful. So can you tell us how your predictive model, performed, if you will, or what did you find in terms of its ability to predict in that test that you gave it? How did it work out?
Yeah, I mean it doesn't it performed moderately well.
Okay.
It showed some proof that we might be able to do this, but it's not at the place where we could bring it into use. It would need to improve in both sensitivity and specificity in order to roll that out in any kind of meaningful way. However, I think for a first attempt at this kind of work, we were quite pleased that we could show that it's feasible. It's sort of like the first step of your stepping stones, if you will, into how this work could be developed.
And I would think that it's a good idea to test feasibility first, because if you went ahead without testing that, you would spend a lot of money and it may not even work. So this was spending less money to see if you even could get it to work.
Yeah, I mean, absolutely. I think we had to start with a piece of work like this, and anything else would have to build on this. And certainly, if we could get the model to perform well enough, then I think with input from the community, when input from, our family advisors or patients with lived experience, how could we build that into something that is usable for the community?
So now it sounds like you've demonstrated that, yeah, this could work. The methods that we thought could work actually produced something. The test results weren't bad. They weren't great, not ready for prime time yet, but they were still pretty good. Where do you go next?
Yeah, I think we need to redo, develop the work further. So it's like anything else. I think when you hear about machine learning, it needs more data, more sources of information, linking more data in. In this case, we think we may be able to get new types of data, like, for example, laboratory data. Who knows what we might be able to access in the future, perhaps developmental data. I think we're looking at something that would take years to potentially develop. But should we get it to a place where it's performing well enough, then I think we'd look at piloting it in smaller studies. For example, could we run even a small pilot within CHEO, for example, potentially, to see if that kind of approach could work.
Okay. How do people who have kids who have been diagnosed with autism spectrum disorder, how do they respond to your work if they've had the opportunity to speak with you or speak with others on your team?
I think it's mixed. I think there's, when I think about doing this work, for example, there's been many times when I've been in clinic and I'll have a parent say to me, of like an older child, say, I wish I'd known earlier, or I feel guilty that I wasn't able to access services or advocate earlier. And I think those are the patients or the families for whom something like this might be helpful. It might also be helpful for individuals who do have difficulty accessing the system. Or are there, for example, individuals who can't even start to get in because they don't have a family doctor. Or, maybe it's they live far and have difficulty getting to a provider. Are there ways that we can reduce some of those barriers by offering a more systematic screen? I think any solution would definitely require family and patient individuals with lived experience input.
So right now, what are you working on in terms of the steps you laid out? What are the specific steps you're working on right now to go to stage 2 of what you're doing?
Yeah, so our current current phase of the project is to try and make the algorithm better.
Okay.
Can we add in better data and more data to see if it can perform better?
So that's two ways that you can check the performance or improve it.
Yeah, that's the goal.
Okay.
Because as we mentioned earlier, it's not ready for prime time. But the goal is that if we could develop it further, then maybe it is at a point where we can start having more conversations to say, what could this look like for the system? What would families find useful? What would the system find useful? Is it trying to offer a screen for everybody? Or if we consider other possibilities, is it maybe, figuring out in these long wait lists for therapy, how to retriage individuals, for example? Or are there ways that, for example, if we could develop a model like this, that patients could, under their own choosing, enter their own kinds of data? For example, if a parent was concerned about their child, could they fill out a checklist and see if that increases or decreases the likelihood, for example? I think there's different ways we could potentially use this kind of an algorithm. I think, the first step is seeing if we can develop it to a place where it performs better, and then start thinking about what the community and what the system how best to use it.
And you mentioned that it would be very important to get opinions from
Absolutely.
from parents and I suppose youth who can provide information. Are they working with you on this second phase?
Yep. So we have persons with lived experience. We also refer to them right now as our family advisors. So it's early days, but they have also already given very useful input, how to frame this work, how to think about it, making sure we don't inadvertently, assign guilt or things like that. So I think it's going to be what I hope will be a very productive collaboration.
So one of the things that strikes me that is unusual in your work and really refreshing is when we talk about precision mental health, we're always talking, unless we take great pains not to do this, we're ignoring completely the community and the general population. We're talking about precision methods at the tertiary care center or the academic health sciences center. You are talking about population precision health, mental health, which is really very timely and needed. And you are reaching out into the community. And you've talked about, a little while ago in the beginning, how you became interested in population screening. What does genetics, for example, do that's different from population screening? Like, how is it different?
Yeah, it's interesting because, as you've heard some of our other speakers today, genetics often focuses more on the individual or the rare situations, which are important. But I think I'm also really interested in what are the ways we can help the most people with one type of approach. Is this it? I'm not sure, but that's part of the thinking of where can we get for a healthcare system that has, limited resources and lots of need. What are ways that we can address it in the most meaningful way that we can? So this has been absolutely fascinating and certainly could go on and talk more. But I'd like to ask you one last question. I'm
What advice might you have for a young investigator who actually does want to look at something like population? Let's say mental health, precision mental health, but it could be population precision health. It doesn't actually. How? Because you're changing. Your perspective changed as you developed, as you grew.
Mm-hmm.
What would you say to someone coming in now who might be interested in that? How should they think about their career, or what kinds of things should they get involved with?
Try to collaborate. As you pointed out, collaboration and co-design is really, really important. I think start networking with the people that do this work. Be patient, because not everything's a straight line to get from point A to point B. And sometimes it's a very circuitous path that we all get to in our careers. And, try to learn the fundamentals so that, when you can think about a project or a goal, what is going to get you to that point.
Uh-huh. Well, thank you very much. I've been talking with Dr. Christine Armour, and we've had a fresh perspective on an expanded version of precision mental health, talking about population precision health. Thank you very much. Thank you so much for listening. Learn more on our website,